Hey everybody. So thank you all for coming in on a Saturday. My name is Enu Perez. I am one of the co-chairs of the GIGU Repro service line for the RFS. And today I have the pleasure of welcoming Dr. Thomas Vogl. He is the director of the Institute of Diagnostic and Interventional Radiology at the J.W. Goethe University Hospital in Frankfurt. And we're welcoming him today to talk to us about chemosaturation. He's one of the recent authors of a Chemosaturation Percutaneous Hepatic Perfusion systemic review and one of the experts on the field. And so to keep this short, I just want to thank him for his time. Thank you for your attendance, and then also welcome Dr. Goethe, Dr. Vogl, excuse me, onto the webinar.
Yeah, thank you for your invitation, and I'm proud that you invited me. I want to share with you in the next 45 minutes our experience development in Europe using chemosaturation. You see on this PowerPoint also there are a lot of co-workers, people from my institution, people from different institutions in other universities. Some of the material you will see was done in joint venture. I have a consulting topic with the company Delta, which is producing the system, and I had one travel grant. Let us look on liver, and I think there's no other organ in the human body where so many different topics of treatment are possible. Here you see on this diagram, you can exactly see what treatment options we have, and especially in liver involvement in cancer, more and more patients are seeking individualized therapies, and the survival benefit will depend on the question of a disease-free interval, on the receptors of the tumors, mutation, biomarkers, previous therapy, patient preference, spectrum of side effects, symptoms, and the location of the tumor. So it's truly complex, and at the end of this seminar, I hope that you will understand what chemosaturation is in the portfolio of interventional therapies in attention. Before we, in our liver and tumor board, and we have in Frankfurt a liver cancer, where we primarily discuss primary liver cancer and like HCC, cholangiocarcinomas, and we have a GI board where we discuss all malignancies with liver metastasis like GI, GU, or dermatology, melanoma. Before we present a case with a liver malignancy, we define in our tumor board whether it's a unilobar or bilobar disease with my surgeon, and I'm grateful to have a long-standing friend, Wolf Bechstein. He trained and with me in the Charité in Berlin and is still the chairman of surgery. So we are together now for about 30 years. So he is defining, is this a resectable or unresectable situation, or possibly a resection combined with a contralateral ablation. We define synchronous, metachronous, and of course my task as a also diagnostic radiologist is to define in the tumor board, do we have extrahepatic manifestations like peritoneum, lymph nodes, lung, the role of PET-CT. And of course, we have in the tumor board people from psycho-oncology, so we have to define is this a symptomatic or asymptomatic situation. Something which helped us a lot in the recent times was to clinically classify the tumors, and so in all liver tumors, we will define a group 1, which is primary resectable metastasis. Here, we are having a daily discussion with the surgeon on is this a candidate for ablation or surgery or first chemotherapy. In liver malignancy, we have potentially resectable metastasis. Think of portal vein embolization, newer techniques like AGIR or double venous embolization. And we have on the right side, unfortunately, at least in Europe or Germany, a lot of patients are showing with liver metastasis of different primaries, and you see they are unresectable, they will be never treatable with a resection. And here, of course, we see that we have a lot of topics like TACE, we have the radioembolization, we have the chemosaturation as a therapy option. Let us summarize how we classify our arterial therapies. And unfortunately, in interventional radiology, we have not so many prospective studies, but of course, we are defining that, first of all, there is methods like the intra-arterial hepatic chemotherapy or so-called transarterial chemoperfusion, which is not so frequently performed. I think in the States, in Boston, is a group quite experienced in that. We have the transarterial chemoembolization. Currently, we have 3 methods. We have the so-called conventional TACE, also including lipiodol. We have the TACE with the beads, and we have also a TACE where we are using resorbable particles like Embocept S. Then we have the radioembolization, and we have the isolated liver perfusion, which is my topic today. The indications, and this is again important, do we have a salvage therapy? So the response intention when systemic therapy is insufficient, or do we have a first-line therapy like an induction therapy? Of course, in the tumor board, we're always discussing, are we able to convert non-surgical patients into surgical? The treatment options when resection is not possible, we will discuss. First of all, is there a tumor-focused or local ablative strategy? Is this patient a candidate for whole organ or regional therapy? Or, of course, we have a strong oncology section in our hospital, and they have every day a new systemic therapy. They have every day a new antibody or angiogenesis. So we have to discuss that, targeted agents, chemotherapy, or now molecular therapies. The mechanisms for the chemoembolization, in contrast to the chemosaturation, is that we, in the chemoembolization, we embolize the liver arteries. So we are inducing ischemic tumor necrosis and try to protect liver parenchyma. That's something we will discuss also in the saturation. We are combining arterial occlusion and regional pseudostatic chemotherapy. Why? Because we think that improved efficacy of chemotherapy therapeutics is induced if we have hypoxia. And we are considering that we have a longer persistence of high concentration of chemotherapy at the tumor site. Here an example of a patient here with melanoma, which we will see later on. Also, it shows that in most of the cancers and metastases in the liver, we have like it is shown here in the MRI. And then if we do perform the angiography, we are using a lot of cone beam CT, blood volume evaluation, and you see we have the central necrosis, and here we have the peripheral hyperperfusion area. And that is a question how we approach that area, how we are able to bring our chemotherapy material as exact as possible into this area where we see that this is hyperperfusion. You see excellently here in the Dyna CT. This is a question, and also like here, by the use of this cone beam CT, we can excellently visualize small lesion here, but you see the potential of the hypervascularity, which is shown here. And we found Dyna CT extremely helpful also for the planning of saturation therapies. Here, after the treatment, you see still in MRI, you see the lesion itself, but you see in the Dyna CT, in the perfusion is after successful chemoembolization is gone. So the role of chemoembolization defined by the role of Dyna CT and blood volume evaluation. What is the rationale for whole organ therapy? Something you can go into your tumor board and say, okay, we are able now that we treat the visible lesions and we treat the occult metastases in the liver, especially in the melanoma. We will shortly discuss also cholangiocarcinoma, other cancers. It permits increased tumor exposure to a chemotherapy agent, and it doesn't matter where it is in the liver. Of course, that would be the wish for the future, that we have sufficient chemotherapy agent. I come to the topic later. And it permits a reduction in the systemic exposure, allowing a dose escalation. So if you consider, for example, colorectal metastasis, and you know about the potential of oxaliplatin or irinotecan, you see that we can escalate the dose if we would be able to perform saturation using oxaliplatin or irinotecan, which is very sufficient in colorectal cancer. The first papers on chemosaturation, it started in 1980, 1990, NCI, and here the first diagrams. You see here the problem in the liver. Of course, we have three vascular beds. We have the arterial inflow, we have the portal vein, and of course we have the hepatic veins in the inferior vena cava. And the first question when they introduced the chemosaturation, I was a little in doubt how to deal with the topic that if we exclude the perfusion, how we do with the portal venous inflow into the liver. Can we really control tumors if we don't saturate also the inflow by the portal vein? I come to that topic also in the following demonstration. The surgical isolated hepatic perfusion, the surgeons were ahead of us. Of course, they showed that the vascular isolation of the liver allows a dramatic chemotherapy escalation. Second, vascular isolation reduces systemic toxicity and thus improves safety. And perfused entire liver during metastasis is not visible on imaging. Several tumor types might respond, and how now we come to the main topic, to the melphalan. Currently, chemosaturation in clinical scenarios is only possible by using melphalan hydrochloride. I will tell you later about the potentials and drawbacks of this drug. What could be improved? It could be a treatment modality, but however, there might be increased morbidity. It's invasive. Surgery could be performed only one time only, and we have a recurrence, and the procedure was limited to relatively healthy patients. So in surgery, chemosaturation was not followed further. Intrahepatic perfusion isolated means it's a regional therapy. It isolates the hepatic flow and the outflow surgical. The liver is then perfused with chemotherapy by an extracorporeal circuit, and 61 the first data. And there are some studies, I will not show them all, so then we have to talk about 2 hours. It shows response rates of 60 to 70% in a variety of tumor types with liver-limited metastasis. Colorectal cancer, there are some larger institutional reports. Ocular melanoma, this will be my main topic today, and some limited data on neuroendocrine tumors. What are the major disadvantages? It's invasive, and an open surgical procedure was associated with these applications you see here, and it could be only done once. This was the first step on using chemosaturation. The first reported clinical use of isolated hepatic perfusion was then followed by minimal invasive catheter techniques. Delcat is currently the only company providing the system, and several clinical trial programs for chemosaturation are ongoing. So 1961, here's the timeline again, in the Roosevelt Park Center, the first surgical perfusion in Yale, the first tested in vivo chemosaturation interventional technique, and 2011, chemosaturation was approved in the European Union, and in Frankfurt and in Italy, we had been the first centers installing this technology. There are 3 points you should always remember. That chemosaturation uses 3 primary principles, and each of these principles has in itself problems, drawbacks, or challenges. The first one is isolation. We isolate the hepatic blood flow. Secondly, the saturation. The chemotherapeutic agent is delivered and saturated. In the filtration, the chemo-rich blood is filtered outside the body. And here is an example, the schematic diagram we might have seen also in a lot of conferences. Here you see the liver itself. You see the implanted catheter via the femoral vein into the inferior vena cava. We are coming to the position of this balloon-based catheter. You see that with the current system, you have an arterial catheter, which is shown here. Mostly cobra or sidewinder catheters are used in microcatheters, which are then positioned in the optimal position of the common hepatic or artery. We always isolate also the hepatic artery by performing coil embolization of the hepatoduodenal artery. Okay, and then you see during the saturation, we have the arteries, which are fully in the liver, giving the full dose of chemotherapy to that area. And then you see on the right-hand side, your radiology equipment, your radiology theater suddenly becomes an intensive care unit, because you see here, this is a filtration, which I'll show you later. Here are the bags, and here you have the anesthesiologist sitting here, because if you start, then the perfusion, some patients might react with blood pressure changes. Some of the major challenges and drawbacks of the procedure is the isolation. On the left-hand side, you see the balloon system, which is shown here. You have a proximal, and you have here distal, and you have a proximal balloon, and here in between you see different holes, and this is again shown here in the schematic diagram, which is shown here also. So which means that the saturated blood is evacuated here via the holes. It is again cleaned in the circulation system, and here the position is shown in an X-ray. You see here the balloons filled with a little contrast so that you can excellently visualize them. And then via these holes, you can inject the contrast agent. You see the hepatic perfusion of the hepatic veins, and you can then see that no contrast is coming all along the balloons. This is very important, and the position of the balloon is not that easy. It's tricky. In some patients, we all as radiologists know that the vena cava inferior can show a lot of variations, and so you have always to control the positioning of the balloons. We also had some procedures where one of our fellows, even myself, we had been keeping the balloon in place by always putting some tension on the position of the balloon. Again, shown here, in the schematic diagram, like I mentioned here, the Chemosat. What you need for the team, and before we do the procedure, every time we have a working list, so we go over these whole topics. Of course, the patient is first had been seen by the oncologist. Also, we had the patient discussed in the tumor board. And of course, we need after the procedure also management by the oncology, because some changes in blood values can be the problem. You need an interventional radiologist, you need a perfusionist. We have seen that in our hospital, the people working for the cardiovascular colleagues are the best ones, and we have an excellent one, the anesthesiologist, the best, somebody who has experience with liver transplantation, because they have similar problems. Pharmacist, you need a good cooperation. He has to prepare the melphalan solution. You need a registered nurse, interventional radiology staff, and critical care specialists for the immediate post-procedure follow-up. So it's a lot of effort. Let's start the introduction to patient preparation. So here we have all the baseline laboratory workup. Something what is very important is also to check in females, young females, on their menstruation. So sometimes it should be blocked in order that you don't have suddenly a bleeding problem. Laboratory evaluation, of course, imaging study like PET, I mentioned, brain, CT or MRI, better MRI should be performed. Embolization, I prefer always to have a good embolization of gastroduodenal artery. Here, optimal position. Here you see the catheters, the balloons filled. This is the area of the flow that is shown here. And then you see what is still a problem. And there is a system from Belgium, maybe coming soon, which additionally also has a perfusion system for the portal vein that might improve then the outcome for these patients. What we have to check, we need an intravenous venogram. we have to see that we have a backfilling of the hepatic veins. That's something you have to recontrol. After 20 minutes, you do always a recontrol in order to be totally certain that the balloons are still in a good place. And normally the left hepatic veins do not fill. So don't work too much in order that you see them. Most of the patients you will not be able to see the filling because they are very near to the heart and the base of the heart. And there should be no leak around the cranial balloon into the right atrium. We come to the most important topic. If you want to install chemosaturation protocol in your hospital, the oncologist, you will visit him and tell him, oh, we have a new system and we want to use melphalan. Melphalan is a bifunctional alkylating agent. It's not cell cycle specific, and the cytotoxic effects are related to the concentration and duration of exposure, and is non-toxic to normal hepatocytes. Here the bioavailability is quite good at 90%. Metabolism is hydrolysis. Half-time is 1.5 hours. That's important. The excretion is done by renal, and some parts of the drug are also significantly metabolized. It's an old drug, so we are coming now to our radiology theater. Here you see a lot of people around. In COVID times, not that easy. You see the X-ray. This is the filtration. This is our perfusionist. He is excellent, very important, our anesthesiologist, and here my staff people also. And you see here, suddenly your angiography becomes really an operation theater with a lot of blood going up and down. And here you see us controlling, again, the positioning of the balloon, which is so important. The preparations I already mentioned. And in our checkup, it's important, again, coagulation parameters, best the same day, even in the morning. Blood products should be available. Platelets, FFP, hydration begins in the night before the procedure. All patients who had a history of hepatobiliary surgery or plated procedures, they have and need perioperative antibiotics. We don't do it regularly in other patients. And you always have to use proton pump inhibitors in order to prevent gastritis, these drugs should be administered according to the guidelines of your hospital. The angiography and embolization, I think that's for us interventional radiology nothing of a very important. It's not a very challenging procedure for an interventional radiologist. But I always do embolize everything what I see, because it's a very long-standing infusion of the melphalan, and I want to be totally certain that we afterwards don't have gastritis or pancreatitis or whatever. And important is the balloon spacing. Normally, Delcat provides you with 2 different balloons, and you can a little adapt it to the patient anatomy. What is important for the hepatic arteries, we are trying to relieve the spasm. Normally 100 microgram of aliquots, usually 1 dose, can relieve that. And after we have given the nitroglycerin, we are performing a recheck 2-3 minutes after the application. Here an example. You see here, after we inflated the balloons, we have here the catheter in place, the microcatheter, which is here, and you see here the angiography. And a lot of patients, especially in large metastases, are reacting with the spasm. You see after the nitroglycerin, you see immediately an increase in the vascularization. It's important to check that, otherwise your melphalan will distribute or has a reflux, or you have a lot of problems afterwards. After the chemotherapy, and this one is diluted, then the hepatic catheter is removed. We are using our infusion pump for the angiography in order to apply the drug. Mostly application time is about 30 up to 40 minutes. The liver is allowed to passively wash itself out. So we continue the filtration for 30 minutes wash out. During that time, our anesthesiologist checks the blood cases. He replaces the bicarbonate, and important is also that you keep the patient warm. After the 30 minutes, we put the pump off, we deflate the balloons, we take out the balloon catheter, but we leave in the introducers. These one we remove then mostly when we visit the patient about 6 to 8 hours later on intensive care unit or the next morning. We have the cryoprecipitate units given upon the withdrawal of the deltoid catheter and the labs, of course, and we reverse the heparin in the ERs with protamine, which you're all well aware of. What is my experience in Frankfurt? We had in Frankfurt 2 phases using chemosaturation. The first phase was a challenge. First of all, we had to convince our oncologist. In the first phase, the filters were not in the quality like we had in the second phase. So we needed a lot of trust in our hematologist because we saw a large amount of bone marrow suppression. Of course, it was a challenge to orchestrate the interventional suite in the procedure itself and the post-operative monitoring by the hematologist, by the anesthesiologist, and but at the very end, we found a very good team, and especially also the people from the perfusion were very helpful. Here you see the first data in a patient with ocular melanoma, recurrent situation. You see the patient had underwent surgery. The patient had underwent also ablation of an oligonodular case and melanoma manifestation. But then there was a immediately drawing back and recurrence with a lot of these lesions, typical for melanoma. You see central necrosis, you see peripheral rims here, which are shown here, and you see after chemosaturation, still the microwave ablation area is shown here, and you see a significant lowering in the number of the lesions. If you look in order to define, okay, sorry, I went back here. I want to show you maybe during the procedures also some cases. So one of the first patients we did was a 53-year-old male. He was suffering from malignant melanoma. He had 2 chemoembolizations. He had radiochemotherapy also for breast cancer, systemic chemotherapy, and here you see a huge tumor, and they started with femurafenib, an antibody therapy here in this patient. You see in the first staging, the tumor significantly lowered in size, and this was then before the chemosaturation therapy. You see suddenly again smaller lesions, which are shown here in the MRI, so after a lot of discussions, you see also some lesions here in the dome of the liver, mainly dominant on the right side. Patient was included into our Delta protocol. And this was in the phase 1. And what you see here, I visited on a regular basis the patient every day. And you see here the thrombocytes went to 0 here. This was a hard time for my team. And the leukocytes were not much better. You see here in 2012. And you see here there was a little increase by injecting of drugs, but overall it took us a long time to bring that patient back to normal. He survived, and interestingly there was no infection, no pneumonia, but we had a hard time. Here after the saturation, we also performed an ablation here after the second microwave ablation, 3 months after saturation. We had a good local control, and for a longer time we had no intention of disease. Our German melanoma trial, which was initiated in Frankfurt, here the study period from 2012 to 2015, we had altogether 8 patients with hepatic metastasis from melanoma. Chemosaturation therapy 1 to 3 sessions. We evaluated 17 patients, RECIST criteria, survival time, adverse events. What were the results in our series here? We had the mean overall survival after the first chemosaturation of 9.6 months, and in the range between 4 and 30 months. time to progression in 2 patients, one patient with 3.6 months and one patient deceased 1.7 months after chemotherapy. Another patient with melanoma, also of the right eye. The first diagnosis was in 2001, hepatic metastasis in 2011. Then he underwent a laser therapy of the melanoma, surgical resection, chemoembolization, SIR, and then we decided for performing the chemosaturation in July 2014 and October 2014. Here, typical angiographic evaluation here. The gastrocnemic artery is shown here. We embolized it, the MRI before showed here the lesion itself. Here you see then the MRI after the chemosaturation, the positioning of the catheter. Here again, no hepatic vein on the left side shown on the right-hand side. And here some spasm during the arterial infusion of the drug, which we treated then with nitroglycerin, what I showed you before. 4 months later, the lesion completely gone. Nearly, there was a little hypervascularity, which is shown here. You see also some structural inhomogeneities, which we most likely defined as chemotherapy-associated steatosis of the liver, with a change in the signal intensity. And 7 months after the second chemosaturation therapy, the patient delivered a recurrence. Also central, you see the increased diameter of the bile ducts, not a complication we have often seen, but there was again an activity. Here you see one of our most famous patients. She's in the health system itself, and so she survived after chemosaturation several years, and we have a nice video. So she was reporting. It helped us a lot in the media because she was more or less in an end stage, and she was able to perform a normal life. So, and she did a great job for us. Okay, we did several trials, and one with Franco Orsi, you will know him from Milano, and we put our patients together and evaluated them. So we had then this time 14 patients. Here again, what is important, the melphalan concentration, 3 milligram per kilogram, given as a 30 minutes hepatic intraarterial infusion. The filtration, here partially first generation, and the second generation, which I mentioned to you already, with a higher efficacy, which was introduced in Europe in 2012. All patients, of course, have to go under general anesthesia. I don't want to bore you with the numbers, but you see here mainly ocular melanoma, cutaneous melanoma, some gastric cancer, some breast cancer, and you see here second generation pre-procedural embolization duration in the hospital was much lower than in our second phase because we had a good learning effect. And here the tumor response rate in a cholangiocarcinoma, not so good in our series. It was better in ocular melanoma, and we had not good outcome in breast cancer or gastric cancer in our series. Toxicity, and this was significant. It helped us also to install our chemosaturation protocol, because with the second generation of filters, you see here the anemia and also the nausea, fatigue also went down. So we had in the second filter generation, we had more patients in the grade 1 or 2 in comparison to grade 3 or treatment required. So this was the first situation that we clinically could convince. Safety topics. Of course, there might be grade 1 to 4 filter-related thrombocytopenia. There might be grade 3 to 4 melphalan-related pancytopenia. So you have to check the bone marrow before. But interestingly, the hematologic events were predictable and could be managed effectively. What we saw also in a lot of patients was a transient grade 1 to 3 increase in transaminase. We had one patient who died from a heparin-related retroperitoneal hemorrhage 30 hours after chemosaturation in this series. What is about progression-free survival? And of course, a limited number of patients. I will show you the international study then, but you see that there are some patients who are surviving then even more than 1 year, and it's about 30% of the patients in this series. If you look at the progression-free survival, it's nearly comparable. Here is a confidence is a P of 0.95. Here's a time to hepatic progression, and you see that nearly all patients in the later phase show the progression. From this study in the European patient cohort, we could only say and finalize that there's a response observed in some patients with cholangiocarcinoma and mainly in cutaneous melanoma. The ocular melanoma performed much better, and of course there should be only used the second generation filter because of the side effects. A trial number 2 was in the German melanoma evaluation. So with the other German centers at this time, we evaluated together our patients. And so you see here for this first phase, we had Frankfurt, we had Heidelberg, we had Göttingen, Hamburg, Berlin. And then we were looking at the child score. We were evaluating on the data. And you see that partial remission after the first cycle was about half of the patient, stable disease 5, progressive disease in 2 patients. So there was a significant improvement. Overall survival time in this German melanoma patient evaluation was 6.5 months. The median progression-free survival was 52 days, 1.7 months. Overall survival better than in our German-Italian study. So we had about 40% patients who showed at least a survival of more than 2 years. So it was a little bit better. The safety, leukopenia 50%, thrombopenia 43%, neutropenia 14%, infection and fever, but no death related in this evaluation. Now let's look at the current published patients and the trials. There is a recent paper in cancer imaging by the group of Arzt, and they evaluated the chemosaturation for liver-dominant metastatic uveal melanoma. It's a single center experience, but it gives us good numbers because they performed these procedures in 16 patients. They performed 28 sessions. And they had overall something we had also seen in our German evaluation, a partial response in 9 patients, 60%, stable disease in 5 patients, 33%, progressive disease in 1. The median overall survival of the first chemosaturation was quite good, with 27.4 months. And the median progression-free survival was about 1 year. You see the SIE, 13 patients grade 3 and only 4 patients grade 4. A clinical trial which was published in Cardiovascular Interventional Radiology also in 19 by our friend and famous Dr. Meyer, and he performed a prospective single-arm, single-center phase 2 study. He had 35 patients with 67 procedures. He evaluated mainly safety. So hematologic events grade 3 to 4 was by definition a thrombocytopenia of 54, leukopenia, anemia, non-hematologic events. And prior to the therapy of liver metastasis, this was a predictor of the late grade 3 to 4 leukopenia. What is the current numbers? And this some data which show you some of the procedures which have been done here. 3 years ago, the numbers were 201 in Europe. I think meanwhile they are approaching about 350. I want also to share my last minutes with you whether there is other indications than melanoma, and there's a European HCC and cholangio trial. It was initiated in Frankfurt and now mainly performed in Hanover. They published in European Radiology 2019, Dr. Marquardt, irresectable CCA, 15 patients, 26 procedures. Overall response rate lower than in a melanoma, 20%, disease control 53, and median overall survival from initial diagnosis comparable to ocular melanoma. And you see here from the first saturation is only 7.6 months. Median progression-free survival is lower than in melanoma. The median overall survival was better in patients who had liver-only disease compared to those patients with local regional lymph node metastasis. I think that's clear. That is what we expected also from the data. Here an example, here in cholangiocarcinoma, which was increasing here by the application of Marquardt, and you see here the rim enhancement, and you see after saturation some partial response, but still you see the amount of infiltration, maybe a little lowering of the wideness of the bile ducts here, but at least a partial control of the situation, which is demonstrated here. And you see here in the later phase, and again here is an increase in the volume. Here again the tumor is invading, and there is a regrowth, which was shown in a lot of patients. Here you see their survival data. Unfortunately, 0.2 in the longer time of survival, so progression-free survival is documented here. What could be study objectives? We want to evaluate the objective response rate. Secondary effects could be progression-free survival, and these are now the topics which hopefully Delcat and the company will further initiate to have some international multicentric randomized trials in order to prove the data. The clinical development protocol is of course here that there are currently some investigator-initiated trials. There's one in Leiden. They treat the metastatic colorectal disease. The HCC I mentioned already, and of course, unfortunately, all these trials are currently performed with melphalan, and of course, we would see a challenge to use these saturation protocol also by using newer and more model drugs. I think here you saw already on the European experience, and there is some, and you need it in your oncology discussions, phase trials, for example, here, chemosaturation trial, randomized 93 patients, and here metastatic melanoma randomized, and so they are currently now evaluating these data with 2 arms, standard therapy, chemosaturation, and then they are performing this evaluation. I found also a quite interesting paper on the hepatic progression-free and overall survival for metastatic liver, and they compared yttrium-90, Y90, chemoembolization, and PHP, and you see here the role of Y90, the chemosaturation, and also here you see at least in these patients with metastatic melanoma, there is, according to this data, improved survival seen after chemosaturation, while this is lower also for chemoembolization and for Y90. My last slide, I want to conclude. Chemosaturation is a challenge. It's something centers should offer. If they have patients with ocular melanoma or some cutaneous melanoma, it is important that you build up a team which is related to expert in intensive care. You need some of your oncologists should be your best friends. Important is a perfusionist. You better talk to your cardiac surgeon and take somebody of his team. You need a good friend in histology, and also the pharmacist is important because he has to prepare that, has to come in time. And I think in patients with ocular melanoma, liver metastasis, this is a potential option for the patients if they have non-resectable metastasis. And we see them in an orchestra of different other methods like embolization, like ablation, and Y90. I think this is my final slide, and I hope I did not take too much time from you, and now I'm open for question on all these topics around the liver and melanoma. Thank you for your attention.
Thank you very much, Dr. Vogl. So if anybody has any questions, feel free to put them into the chat. I do have a question. You mentioned that these patients typically get admitted the night before, and then just can you talk a little bit about kind of a little bit further about kind of what the prep is prior to the procedure? Because during the procedure, you're also kind of cutting off the entire IVC circulation, and so how do you, like, what specific steps are you handling to kind of deal with that hemodynamic change which is, I'm assuming, very significant.
Yeah, okay, thank you for the question. It's important that we always take the patient one night before, because we start early in the morning. Normally we try to do 2 procedures in one day, because then you have the team around. You have to check for example menstruation with the females, the gynecologist also has to be checked also. And we check again the blood values. And what you mentioned already, the main part is the circulation. As soon as you start the filtration, if you pump the blood from, let's say, if you extract it from the hepatic veins directly, there's a phase where the blood pressure is dropping down. And anesthesiologists who are working with liver transplantation, they know that phenomenon. It's the same if they open or connect the new liver, is nearly the same topic. We have at the beginning with the phase 1 or the generation 1 filter, this was a big challenge. With the generation 2 filter, and we saw that it became much easier, but still it's a critical phase. And in a way, these patients also should be checked for any types of cardiology problems, renal problems, and so on. But mostly these ocular melanoma patients, they are more younger, they are physically in a good situation. What we do after the procedure, we have the patients for one night on an intensive care. We are using the 24 hours flat of our anesthesiologist, where he controls the patient. And the next morning, normally we put the intravenous sheets out, control the patient, and then he goes to a normal ward. And as I showed you, this time of the normal ward can be between 4 and 8 days if we don't see any hematologic problems.
Okay, thank you. I don't see any further questions on the chat, but I do want to thank you so much for your time, and thank you for kind of, a lot of us, I think, is some of them maybe the first time we're hearing about this procedure, and so thank you again on behalf of the RFS GIGU.
No, and I'm offering any help. If somebody has certain questions, write me an email, or I have all the literature I can email, it's no problem. So we are very open to that, and we are still hoping that the company providing the system is moving forward in using drugs like oxaliplatin or irinotecan. And I think it's important for radiology that we are in the field, that we are prepared for that, because that might be a big challenge, and that might be very helpful to those patients who are suffering from still active tumors in the liver, especially in colorectal liver disease.
All right, yeah, it's good to hear. Thank you so much. Okay,
have a great weekend. And here we'll see you hopefully at a meeting as the SIR from face to face, and person to person. I would appreciate it.
Looking forward to it. Thank you.
Yeah. Bye bye.